Hey friends, welcome back to the Journal Feed. My name is Nick Zelt, and this is the only place where you get to get spoon-fed the latest and greatest of emergency medicine. This is the audio version of the past week's summaries, which this week were brought to you by our authors Vivian Leigh, Joshua Belfer, Clark Strunk, Rebecca DeFabio, Shannon Marcus, and Clay Smith. Okay, let's get straight into the first article, which was titled Advanced Trauma Life Support 2025, a brief review of updates out of the Journal of Injury. All right, so last year in 2025, the ATLS did release an update to their typical guidelines, and this is just going to be a quick review of what's new from that. Likely the most prominent change is that they are focusing on exsanguinating hemorrhage as really the biggest, most important thing, and so they're moving a little bit away from the typical ABCs. Now, I think that most of the world in terms of trauma have already done this. And usually that's called doing CABs instead, putting circulation first. However, for whatever reason, ATLS decided that they didn't like CAB, and so they wanted to do xABCs. And so X at the very beginning stands for exsanguinating external hemorrhage, and this is the first step in your resuscitation. And this is definitely the right thing to do, but now it's moving bleeding out of C for circulation and up to the front of the alphabet. Now, I don't mind this, but it's not as catchy as saying CABs or ABC and a little bit different. xABC, it's a little bit awkward, but, it gets the point across. What's really important is that you stop the bleeding up front because this is what kills most trauma patients. Put on a tourniquet if you have to, wound packing, pelvic binders, whatever you have to stop the hemorrhaging. Interestingly, also Rabo is getting a little bit more of a role here, despite the evidence being rather hard on it in recent years. So I was surprised to see that as well. They really do increase their emphasis on kind of damage control. So just, trying to keep the patient alive until they can get to the operating room for the most part without doing any harm. Although you should not be using vasopressors, certainly not routinely. And as usual, we want to minimize the use of crystalloids as a bridging fluid until products or whole blood can be obtained. Really, if you can, just go straight for that and skip fluids. Early activation of massive transfusion protocols is important as well. And they gave a little bit more emphasis on using kind of decision rules like the ABC tool, the assessment of blood consumption, for deciding when you should start those transfusions. And when you are doing transfusions, 1-to-1-to-1 component therapy is the way to go, or low titer O-negative whole blood when available. TXA, of course, still should be given within 3 hours of major hemorrhage, 1 gram and then 1 gram infusion, or if it's a traumatic brain injury, then just 2 grams up front. Once you've moved on from the exsanguinating part, then the airway is still very important, and you should take the airway after you've resuscitated as much as possible if you can wait. Epidural laryngoscopy is now recommended as the first-line laryngoscopy and no longer as an adjunct, and this seems appropriate. RSI is still going to be the way to go in terms of what meds you're going to be giving and how you're going to actually intubate these patients. Spinal motion restriction is now a little bit more selective. They want to be criteria-based. There's a de-emphasis on rigid collars because we know that they can do harm and they don't seem to do that much good, and you should really be avoiding them in low-risk patients, such as patients with penetrating trauma. They're very unlikely to have some kind of a C-spine injury fracture. Moving on from patient care, ATLS 11 really does try to focus down a little bit more on leadership, communication, broader systems, and these are very important parts of care for your patient, particularly if you're not at a trauma center yourself and you have to organize to transfer your patient. So for the most part, no big earth-shattering changes for ATLS here, just little tweaks that you should still be aware of, and if anybody says that they want to cover their xABCs, now you know what they're talking about. Okay, then let's skip to the third article, titled The Effect of Neostigmine on Attenuation of Pro-Inflammatory Cytokines When Given as an Adjunct Therapy in Septic Shock, a randomized control trial out of the Journal of Critical Care Medicine. All right, so part of the thing that does, bad stuff to you when you get something like sepsis is that you have a lot of inflammation. So there's a lot of cytokines that are going around. People talk about cytokine storms and things like this. And so theoretically, if we can calm down some of the inflammation, then some of these patients are going to have better outcomes. For the most part, it's not like the bacteria is actually like eating away at your whole body and making you this sick per se. If it's neck fash, then perhaps, but in most cases, not necessarily. A lot of the harm that's done to you is the inflammatory response, which causes your vasodilation, your BP to drop, and then you get very sick, and this is what happens. So if we can calm down some of the inflammation, then some of these patients might actually do a fair bit better. Now, the thought by these authors was that if you give neostigmine, so a pretty common drug that we at least know of, even if we don't use it very often. Anesthesia uses it fairly often, but in the emergency department, I've never reached for it at all. But this is a cholinergic drug, which is said to have some anti-inflammatory properties through the cholinergic anti-inflammatory pathway. And so if we gave an infusion of this, perhaps we would decrease the amount of inflammation that's in this patient's body, and they would have better sepsis outcomes. Apparently, there's a study out there that already has shown some promise, which is to say that it lowered the SOFA scores at 5 days, and this was primarily driven by less pressor requirements. These authors interpreted that the knowledge gap was the lack of cytokine measurements, which is, of course, not patient-centered at all. I'd say it's a lack of mortality benefit in the previous trial and other patient-oriented outcomes. But if they want to measure the cytokines, then go for it, I suppose. And thus they made their primary outcome TNF-alpha, which is a very common pro-inflammatory cytokine. Regardless, they did a single-center, double-blinded, randomized control trial of patients with septic shock, comparing a low-dose infusion of neostigmine over 5 days versus an infusion of just fluids, which was their placebo. And they found what they were looking for, which was a significant decrease in TNF-alpha levels when giving neostigmine. Of probably more important note is the rather significant finding of 28-day mortality, which was 27% in the intervention group and 54% in the placebo group, which was statistically significant. There was also significant reductions in SOFA scores and Apache 2 scores, so it seems like we were getting a heck of a lot of action out of neostigmine here. So while these results seem like flagrantly positive, and I don't have an immediate obvious cause to explain all of this gap in terms of methodology problems, I think this lacks a little bit of physiologic rationale for this degree of benefit. That being said, when you get such promising results, and the previous study was also promising, then, and it's pretty easy to give, it's pretty safe to give as well, then I'd say it warrants more investigation. Especially when you find such significant results in a fairly high-quality trial. This is a double-blinded, randomized control trial. So yeah, let's look into this a little more. As of yet, though, I don't think I would advocate for anybody starting neostigmine infusions on any of their septic patients. So in a spoonful, I'll believe it when I see it, but this study did seem to show some high-quality evidence to support the possibility of neostigmine infusions to help reduce the inflammation seen in septic shock and improve outcomes. And that's it. That's all from this week. Let's do a quick wrap up of all the articles that we talked about. From the first article, we just did a quick recap of the ATLS guidelines from 2025, as ATLS tries to sell us on xABC instead of CAB. The point is the same though, trying to control exsanguination as your first priority in patients who have trauma. Then from the third article, not for use in humans just yet, but neostigmine is still being investigated as a possible treatment for sepsis because it might reduce the amount of inflammation. This trial was quite positive, but will need more research. Now, if you are hearing this right now, then you are not a part of the members feed, and so you missed 3 articles from this past week. What articles did you miss hearing about? Well, we covered an article on the modified Valsalva maneuver, comparing it to the standard Valsalva maneuver in children. Then we talked about whether or not you can give injectable buprenorphine and whether the outcomes for that are as good as the sublingual form. And lastly, a review of the drugs available to you for opioid use disorder. Links to all the original articles can be found at journalfeed.org, or just follow the links in your show notes. Our goal here is for you to keep up the easy way through spoon feeding. Thank you.